ECG, radiology, and things like that through our video channel library. We'll guide you guys on that one. Okay, so this is the thing. Also, Dr. Tanmay also takes a special CG class in especially these sessions, but other than that, one, there is also radiology, fundoscopy, growth chart, contraceptive ethics, those related classes you will also receive in this batch. Okay, so talking about this thing for those joined actually. So here, I mean, one more time, and we'll go for live on this particular recent months. At the same time, 1.5 year, which has been already conducted, file plus videos will be given at the same time. And here we go today. Today we are starting September. September might take 2 classes actually for us here. Okay, so if the instructions are clear, before we proceed, I think if I like to take 1-2 questions. If there is 1-2 question, feel free to let us know in the comment section. So you can come back to that one later. I would have liked to love to take the first class, but unfortunately, I have a weighty exam coming up in next 7 days. So I'll be little available in the first 7-8 days. So Dr. Tanmay will also conduct, and he's been always been pioneer in taking recall batches too. So we too often take. Previously, there was other tutors because after Dr. Tanmay coming in, we have been conducting together. So hopefully, any support on the thing, he will be also there to guide you guys actually. So if there's Dr. Tanmay is here, if you can say hello actually before I left actually.
Yes, I'm here. Thank you for introducing me. And hello, everyone. This is Dr. Tanmay, and I'll continue after Dr. Shahriar ends his session.
Yes. Okay. No worries. Just check your microphone, Dr. Tanmay. I mean, if you just can say hello, I would just like to check. Sound was not 100% clear, I think, to me.
Okay. Hello. Is it clear right now?
I think people can judge actually from the both voices. I think if I'm not hearing more correctly.
Okay, guys. Can you please respond? Is my voice is clear? Or not? It's not clear. Okay.
Yeah, it's not clear. Yes.
Okay, I'll make it right
you have
this time. Yeah, sure.
Yeah, you can. I think log out and log in actually. So I mean, it's better. That's why we check the microphone, right? I mean, if you're going for a concert, I mean, Dr. Tanmay has been guitarist also, so he knows very well. Before we start a concert, it's always better to check the, the jamming. Yeah, so it's a good jamming that has happened before we start. So you can just log in, log out now, and let me start the session.
Okay, sure.
Thank you so much. So yeah, thank you. Yeah. So here we go, guys. So September session. Are you ready and are you excited to start? I hope so. It is yes. If you are excited, do let us know in the comment section. So here we go. Before we start, I mean, this is the thing. You can take it live. You can take it recorded. These are the options available. As you can see in the left-hand side, these are the 2020 files which have been given to you, and also there is 2021 files that's been given to you. We'll be conducting also the latest 6-7 months at the same time, including a special session during the month of November when exam is going on. There's a lot of recall we also collect, so we'll also like to help you on that one actually. Okay, so that's the thing. Oh, one more information. Sometimes some doctor asks, doctor, in 2025 I didn't see April and May. Where is that? Answer is, the pandemic when it started, actually there was 2 months that AMC was totally shut down worldwide. So April and May were those 2 months actually, like last year, 2020. So that's just to alert you guys, yes. And apart from that, whole 2021, October, November, if anyone is a February and March candidate here, they will be also updated with the February and the March actually. You can also use these videos later on after the classes. So it won't be a problem. In case your exam is cancelled, you can also use that materials actually for a time being, actually 6 months. You can, keep using them. All right, with that note, we like to start the session, and, let's go and start the first class. First question is coming out on your screen. Here we go. Okay, so here we go. As we can see, a 30-year, who was in your clinic, follow up on esomeprazole, yet the gastric pain, epigastric pain persists. So what do you do? So you try to guess in next few seconds. Maybe I'll give you 15 seconds to think what we should do next. This is a September question, very latest question. All right, everyone. So I hope so you are done with participating. So most of the people have answered this one as isomeprazole. I hope so you are guessing the correct. What is the diagnosis here? So your diagnosis, if I'm not mistaken, you are thinking this thing as a. Before I left, I mean this slide. What is your diagnosis, guys? What is your diagnosis here? It's the typical case of ZERD. A typical case of ZERD. So GERD, if you remember, if anyone has also attended my 5 months course, typical ZERD, I mean, we started with proton pump inhibitor. Symptom persist. What we do next? We continue the same drug or we change the drug. There's another option that comes. If you remember, double the dose. If you remember that option, double the dose, right? So anyways, I mean, the double the dose option is not there, but continue with this puzzle. That was the thing. Two more quick information for ZERD. The initial testing, if you have to do testing, is always been the barium. I repeat, esophageal cases, barium, always an initial. Now, how to confirm a case of ZERD? Your answer will be 24-hour pH monitoring. Now, there is an option of endoscopy that comes and, which also might lead you think here, if you see the options, which also might lead you think here, why the answer is not, A or 1. I mean, send for endoscopy. Can anyone guess that one, why it is not? Because I have given the information. Is it an indicator? I mean, there is pain persist, and is that an indicator of endoscopy, my dear doctors? Is that an indicator of endoscopy? The answer is a no. Like here, unexplained weight loss. I mean, if something is related to cancer, then only when. So it's moreover related to cancer related symptom like weight loss or vomiting goes on and this sort of things. Anemia is also indicator like blood is losing by some other means. Okay, so this is the thing. So we continue going with the esomeprazole. Clear? I mean, it's clear, I think, very clear. Okay, so because no red flag indicated, if you have red flag, then you consider endoscopy. It's a little bit, from my drawing in the classes and the things, that's okay. If I just highlight them, don't get scared. ZERD, clinical feature, we all know most cases they are obese people, then we notice there is nocturnal cough, bloating, heartburn, water blush. I repeat, nocturnal cough, bloating, heartburn, water blush. If it's a small kid, then milk flows freely from the mouth. I repeat, if it's a small kid, milk flows freely from the mouth. That is another option. We already said the investigation barium, the best being 24-hour pH monitoring. And in the treatment part, if you can see PPI, and later you can double the dose, or you can say continue that one. If we consider about some complications, esophagitis, stricture, anemia, Barrett's. I repeat, esophagitis, stricture, anemia, Barrett's. Now, Barrett's is a two-edged sword. If you remember pathology, it's a pre-malignant condition. Sometime you will be asked about the Barrett's esophagus. Sometime, I repeat, you will be asked about Barrett's esophagus. A quick question to all my dear doctors. To diagnose Barrett's esophagus, what test I need? Barium, I need 24-hour pH, I need endoscopy. To identify Barrett's, what do I need? Barium, 24-hour pH, or I need endoscopy. The final answer is a endoscopic biopsy. Final answer is a endoscopic biopsy needed. Otherwise, you cannot see the metaplastic changes which you are looking for. What metaplastic changes? Adenocarcinomas, you can see. A famous mnemonic here, 1/3 AB. 1/3 means lower 1/3 of esophagus. A means adeno, A means adeno, B for Barrett's. So that is the 1/3 AB. A very popular question, sometimes those comes here. Even it one time tested even in my exam long back, and it came to some of my students, and you see it keep coming this sort of questions. One time this question, that question. What is the follow-up routine for Barrett's esophagus? A person, a male with a 40-year diagnosed with Barrett's. What is the next time you like to, follow up this person? 6 months, 1 year, 2 year, 1 month. So that is 2 yearly. I repeat, extra note, extra important information, 2 yearly follow-up. 2 yearly follow-up. Clear? Another thing, the upper third is related to squamous cell carcinoma. The upper third is related to squamous cell carcinoma. One more thing, in case of Barrett's, actually, if there is a dysphagia, now there's two things we learned about dysphagia: dysphagia for solid, dysphagia for liquid. So the big difference, dysphagia for liquid mostly related to achalasia. So sometime with the dysphagia, you may have to make a diagnosis. Quick question, dysphagia for solid, what you want to diagnose? Cancer, ZERD, or achalasia? Dysphagia for solid, cancer, ZERD, achalasia first. Answer, cancer first, cancer first. For ZERD, it is always a last feature. Summary, dysphagia for solid is a last feature in case of ZERD. Initially, they don't have symptom. The summary is, what is the early symptom of ZERD? What is the early symptom of ZERD? Before I left this slide, this is the last question. What is the early symptom of ZERD? Yes, my dear doctors, this is the heartburn or night symptom. Heartburn or night symptom. Another thing to consider, heartburn never happens in case of achalasia because tight is sphincter. ZERD, loose sphincter. Remember, obese person, loose. So loose sphincter. Okay, so that's end of the ZERD relevant thing. Is few more information taken from the Davidson. If you can see here, esophagitis, Barrett's, anemia, valvular structure. This file is already been uploaded in your Google Drive actually. If you update more, we'll update again actually, no worries. So these are few information, assessment of epigastric pain. You also need to know some of the differentials. I mean, you can just go ahead later. That'll be fine for you actually, all right? There's a last one line. We need to see the severity duration of esomeprazole actually. So continue with the esomeprazole. That's more evident. Okay. From where we take the references mostly, John Murtagh, RACGP. Then we also use, if it's a child case, RCH we use. It's a good one. Apart from that, other textbook like Davidson we use or Oxford we use. So most cases, these are the books that's been used as a reference. Next question. I hope you're happy with the answer for the last one. A woman with 28 weeks of gestation has a DVT following 6-hour flight. Duplex ultrasound revealed a clot in the popliteal vein. Enoxaparin, I hope so you know what is enoxaparin. What is enoxaparin? Yeah, this is enoxaparin. So given for 7 days, how will you continue the management? So pregnant, enoxaparin given because duplex ultrasound clot in the popliteal vein. My first question, in a pregnant, can we use the warfarin? My first quick question, in a pregnant person, we use warfarin, it's a big no, right? So in this case, we can go with a PROS here, right? We can go with a PROS in this case. Stalking, is this a case for this one now? Not really. I mean, it's a contradicting. It's not like the ideal. We have a better option here. Better option is a drug we can use which prevents further this DVT to form pulmonary embolism or heart attack or any of those serious issues. Why are we afraid of DVT? A question that is coming. The DVT can dislodge, the thrombus or embolism can dislodge and go to your lungs and cause pulmonary embolism, and go to your heart, can cause MI, and can go to your brain and can cause a stroke. And if it's go to mesentery, I mean, it can cause mesenteric ischemia. So, but anyways, we don't want this thing to happen. We don't want this patient to feel extreme pain and most importantly, death, avoid death. So low molecular heparin during pregnancy. This reference is given in John Mutton. This reference is also given in Davidson medicine. Davidson medicine, you will find an extra box just after the TBT and pulmonary embolism mentioning the safety margin in case of pregnancy, where you will find heparin can be used. Also, that's the med school, I think, concept that heparin is safe during pregnancy. Okay, so C3 is been more correct. C or 3 has been more correct. A little bit more evidences here. Evidence base showing low molecular heparin being used as anticoagulant for pregnant, and it's a safe for the fetus as well. It's safe for the fetus as well. So you may have advised heparin for 7 to 10 days after birth, even after birth, or sometimes 2 weeks after birth. Okay. You can check this thing later, no problem. So next question, let's move. And here's a nice chart, flow chart, and chart like this always easy to remember. You know what is the benefit of using flow chart? When you see into a flow chart in different angle, I mean, it's always you need to check the angles. This is angle, this is angle. Okay, these are the angles. So it's always easy remembering. Okay, so figure it out. Don't get afraid when you see a chart. Actually, don't get afraid of that. Okay, so that's one of the things. Will be useful for you. Will be useful for you this chart. You can have a look, risk factors given in tables and the risk assessment and so on the thing. Well, don't forget to read about, like this is also kind of risk assessment, kind of like a risk assessment, high risk, intermediate risk, or other sort of risk. But one more information you also need to understand. Similar type of lot of things you need to study, which I often call compare and contrast. So with that one, you also need to read CHAD scoring. If you go to cardio, so CHADS2 score. Do you have any idea about CHADS2, guys? It's also kind of similar like, and it's even more important. CHAD scoring. CHAD scoring is actually that is being done in case of atrial fibrillation plus chances of thromboembolic manifestation. So use this method called CHAD scoring. Okay, depends on CHAD scoring. We decide. I mean, there's a score 0, score 1, score 2. So check yourself later. So score 0, nothing, or maybe aspirin. Score 1, aspirin. Aspirin. Score 2, warfarin. Okay, so this is another way of asking things in the question. This is another way of asking things in the question. Would love to check this one. Like if I ask one more thing, I hope I'm not boring you guys. If I ask you one more thing, sorry, if it's about pancreatitis, what criteria has been used for pancreatitis? I was talking to a student called for something for plaque preparation. She wants to start 1 month later. When I asked like why you want to start 1 month later when there is a class coming up, is it because my husband is sick and he has been diagnosed with pancreatitis? So I'm so sorry. So then I asked him, you know, what's the criteria currently? So what criteria was that? It was called Ranson's criteria. Okay, have a look on that one. Another thing, something if it's about the heart, and there's a score called TIMI scoring system. Anyone heard this name? I mean, that doesn't tested in exams so much. So far, I have seen CHADs coming. So far, I have seen the Ransons coming in the exam. Now, how about TIMI scoring? So TIMI is for what? Any cases you have 10 seconds to think. Brainstorming, come on guys, little brainstorming. Okay, no one? Plus 5 seconds? No one, okay. Some people are trying to Google it now. This is something related to MI. Okay. So TIMI scoring is used for MI cases actually. Okay. Maybe some of you didn't know that. That's okay. Have a look. Maybe in future it might come. It hasn't been tested yet. Next one, interesting question. A 28-year-old complains of ability to raise shoulder and difficulty in walking and become tired easily or fatigue. Lab shows raise ESR, raise CK. What is your diagnosis? This particular thing, if I just highlight this part, what is this condition is called? It has a name. You know, you need to also understand and figure out certain things. This situation, inability to raise shoulder, this has a name actually. What is that? Okay, we'll come to the answer, don't worry. But how about this thing? Ability to raise the shoulder and the thing is well done. That is called proximal muscle myopathy. When we consider proximal muscle myopathy, there's a lot of options: polymyositis, dermatomyositis, polymyalgia rheumatica, and one more option that is missing. What was that? See, we can guess actually things are missing. Drug. So that can also cause proximal muscle myopathy. Understanding the question? I mean, we are in right direction now. Okay, but how to make a diagnosis? Most 90-95% of the time with a question like this, you will be given lab. 99-90% time you'll be given lab with this type of question. If not given lab, 10% of the other cases that question also comes with, you know, lots of clinical feature given in that case. Okay, so that's another way you can make a diagnosis. Okay. Ability to raise the shoulder and difficulty walking. To be honest, this is common in all 3 or 4 of these conditions, but certainly it's not SLE. SLE will have systemic manifestation, other systemic features. Remember, there's 11 criteria for SLE. I mean, some of them will be present, so it's never SLE. Okay, but we can see lab, raised ESR, raised CK. Is this indicating something? Raised ESR, raised CK. Okay, let's come to that one. I mean, you have to remember this, guys. Polymyositis, poly or dermatomyositis is same thing almost. Just dermatomyositis, there is extra rash because the name derma, or polymyositis. So they are similar, first of all. In both cases, ESR and CK, both raised. Clear? I repeat, my dear doctors, in both of these cases, it has been raised. Polymyalgia rheumatica, ESR raised, but CK normal. Drug-induced, you know, especially statin, that is very popular one, we know, but steroid can also do. CK and ESR remains normal, like totally normal. But in our case, what do we see? In our case, we see raised ESR, raised CK, diagnosis please. Raised ESR, raised CK, diagnosis please. So that's surely the winner is this one, polymyositis is the winner. So polymyositis being the winner, don't worry, just remember that previous chart I gave. Okay, so that'll be fine. Okay, I'll hold in that one so that you can write one more time. This is the main chart. Polymyositis, polymyalgia rheumatica, drug-induced. I'm holding here for 10 more seconds. I hope so. You need to write few documents. Taking notes during the class always enhance your study process. That's very good. Having a study partner is also good. So one, if you take notes, no matter if it is their theory and things, if you take notes, it's good. If you put in your JM these informations by small cut piece like this, I mean by hand drawing, put in JM, it's even good, even better. Third, if you have a regular, you know, study partner, that's very, very good. Okay, and of course, before exam, you know, you discuss as much as possible. Actually, you know, you can go with a 6-8 hours of study, you know, before your final exam or even more. Okay, so these are few tips, I mean, from my side. Also, don't forget to review last 1 year of recall, at least in the last month. At least in the last month, you review last 1 year. In the last month, review 1 year with your friends. See, answers can be changeable. The answer we are telling 1, 2 can be controversial. Okay, so but the discussion you are doing and you are enhancing the knowledge, that will save you in the exam hall. It's not like I have given answer this or Dr. Tanma has an answer given this and you just memorize it. That will not help you passing in the exam hall. Your merit, your ability to crack the recalls, they will try to confuse you as much as they can, but you have to understand what they try to say, see the questions. New update in AMC, I hope you heard. From now there is no flag option. Now there is no flag option. So this is interesting. Now there is no flag option. That means you cannot go back to the previous questions after finishing the exam. No flag option means cannot go back to the previous. Previously, we used to say our candidates, okay, quickly finish your exam, avoid the confusing ones, because in the last half of the exam. So let me just take a little thing here because these are important. So 50, 50, 50. Suddenly it looks like the Britannia biscuit, I guess, but this is another 50, 50, 50, 50. Okay, total is 150 questions. Now, which part has highest marks or less pilot question? Which part has highest mark or less pilot questions? So that means we want to hear non-pilot. Non-pilot question has full marks. So in the last 50 or especially last 30 are pure, last 30 are your pure exam questions, I mean. Okay, and even some cases it's even more easier. Question from one director. So we can't change the answer previous question. No, once done, you change the slide, all gone. You put an answer, you finalize it, go to next one, all done. Previously, if we had confusion, we flag it, we can check it later. Clear, guys? All right. So these are some of the informations. These are some of the information. So 50, 50, 50. So the last segment, you have to go there, remember. Even if you're running short of time, in the second part, they try to kill as much as of your time. Second part, they try to kill as much as your time with ethics question, this question, that question. Please remember this word that you have to go to an end because the end questions are more easier often, or even at least carries more marks. Do not leave any question because there is no negative markings. Okay, so at least you can quickly go scan and attempt it. Some of the questions you might find very straightforward at the end. Okay, this little information we just go through: polymyositis, dermatomyositis. Previous question: White's nose dermatomyositis. Previous question. All right, you tell. I guess that one. I think maybe others can answer that one so quickly. Come on, guys. Why no rash? Yeah, no rash. So dermatomyositis will include rash. Poly will not include rash. Okay, very clear. So poly and dermatomyositis. Okay, stubborn boy, 13 years old, rude to parents, rude to teachers. What disorder you are thinking about? Conduct, ODD. ODD means occupational defined disease. ADHD. Question: is it supporting ADHD? First, let's exclude. Is this age is supporting ADHD? Answer no. So we can exclude that one out. Now 13-year, rude to parents, rude to teachers. So what do we think? Conduct or occupational defined actually? Now, does anyone knows one interesting thing? It certainly looks to me As like saying to all of you, occupational defined disease. For me also, because disobedient children, and if they're not giving any criminal, conduct is related to criminal activity. Now, my question is, the person is 13 years. Do you know what is the age group of oppositional defined disease? If you don't know, can you Google it? And let's learn in that way. Okay, so that you remember it. Any guesses? 'Please check again, my dear doctors. "12 to 17 for occupational defined." No, that cannot be. I mean, that's total. I mean, because school going kid, it's happening. So it's definitely not like 12 to 17. I don't know from where you get this. 12 to 17, it cannot be. You should also apply logic, not just Google. It's very common in a school going. Okay, so somewhere what I learned, it can be up to 11, 12 years. I mean, that was, I was also checking, I mean, with that one, what is the problem with this question actually? Somewhere I figured out that oppositional defined is actually 11 or 12 years. It varies with some of the books. Now, if it is like that, now this question, when you take the right decision after going to the exam hall, you go to the exam hall, you see along with this age group, some criminal activities given. Like example, even harming a pet. In our country, we may not consider that one as an offense, but in those countries, harming a pet is an offense. Okay, so if there's example something like that, and 13 years, it will be conduct in that case. But nothing given in that case, maybe you can consider as a occupational defined. But because age-wise, it's not supporting. Age-wise, not really supporting occupational defined disease. Clear, guys? So this question, I would say a bit incomplete because it is just given even less than a line. So when you go to the main exam, the question would be at least 2-3 lines long, or even 4 lines, since it's a psychiatric question. So take the decision wisely after entering into the hall. Okay. So two more information here. More than 12, and criminal activities, conduct. Now, no activities go with the occupational defined. That's the summary. All right. A few more additional things: treatment, most cases counseling, family therapy. These have been given, and yeah, this can be useful if you guys can see. Overall things have been given. Overall things have been given. It will be really useful for you. You can take a picture of this part. It is newly added into the slide. Conduct. This is your conduct. ADHD. The biggest difference, ADHD is up to 12 year, and conduct from 12 year to 18 year. That's the difference. Okay, so those are the things. In some cases, social phobia, that can be also you can consider, as I said in the previous one, occupational defined. So these are all at the DDs of occupational defined. So the biggest difference with the conduct disorder with occupational is severe behavioral issues, especially towards, I say, pet animal or other person with destruction of property. Anger is in like, ferocious level. Great. So this will be useful for you in future. Okay, that's book related to Dr. Tanmay, some additional nice information. I have checked that one, very nice book indeed. So you can also check this reference from this book if you have. So here's like I say, information. The onset is gradual, becoming evident before the age of 8. So this here we have information. It's become evident. Okay. So this is some important information here before the age of 8. And as I said, I will reconfirm that one, but I read recently it can be up to 11 or 12 years actually, if I just go with the age group. Okay. All right, patient presented with the serotonin syndrome clinical feature. Do understand, sometimes they will give you actual features like agitation, tremor, pupillary change. Sometimes there is a drug history of taking these 2 drugs. Okay, so the question can also come as scenario like that, and then they will ask you management. But here, maybe the recaller just directly said patient presented with serotonin syndrome. So what is the next step of management they're asking? So I think if you guys remember, if